seen video too? Okay, some here, some here. Okay, so help them out, guys, if they can't.
As you can. And if the right one goes all the way, let it go all the way. Good. And this is better than a week ago. He had less than 90 degrees when he first came to see us. Now back down by your side. And I'd like to see you bring your arms up to the side this time, as high as you can go. Will the other one go higher?
Yeah.
Yeah, okay, great. And back down. Now let's have you take your right hand and reach up behind your head. Okay, now we'll put that one down. Let's reach up behind your head with this one. So we look at functional range of motion. Very, very painful. Okay, and back down. Can we reach up behind the back with the right one? Up this way.
Yes.
Yeah, good. And we'll do the same with this arm. So he was only getting to his retrotrochanteric bursa a week ago. Now he's getting back to his upper glute, which is much better. All right, great. So,
Do you want me to play it again? All good? I have, did someone watch where nothing about what dysfunction this patient has, but just about this image itself. Does it tell you something where the PT should be, where the patient should be?
The PT is sitting lower than the patient, is that what you want?
Should the PT be guarding or something?
and try to lift those arms straight in front of you as high as you can. And if the right one goes all the way, let it go all the way. Good. And this is better than a week ago. He had less than 90 degrees when he first came to see us. Now back down by your side. And I'd like to see you bring your arms up to the side this time, as high as you can go. Will the other one go higher?
Yeah.
Yeah, okay, great. And back down. Now let's have you take your right hand and reach up behind your head. Okay, now we'll put that one down. Let's reach up behind your head with this one. So we look at functional range of motion. Very, very painful. Okay, and back down. You'll reach up behind the back with the right one, up this way.
Yes.
Yeah, good. And we'll do the same with this arm. So he was only getting to his retrotrochanteric bursa a week ago. Now he's getting back to his upper glute, which is much better. All right, great. So,
Anyone observed? Yes.
So he was in a position so that the
Say that loudly,
he was
Emily.
in a position so that the patient could mirror his behavior.
So that he should be in a position where the patient can mimic his behavior. Why?
Because it's additional input for the patient.
That's one. Any other reason that you think the therapist should be in the front or in the side? If you were to take care of this patient, where would you position yourself? On the side, in the front, on the left side, right side, in the front, behind them? If you were to evaluate a patient, yes.
I would probably move around.
You will move around, okay?
Yeah, he doesn't need a stabilization because doesn't need assistance because he's not.
So you're thinking of assistance, okay? Anything else?
No, I mean strong assistance.
That's fine. So you're thinking of assistance. Anything else? So you can, my basic question is, when I evaluate this patient, will I choose to be in front of the patient? Will I choose to be on the left side of the patient? Will I choose to be on the right side of the patient? Would I be behind? Would I like to move? Why? Yes, movement does happen, but are we checking multiple different planes here? It's a cardinal plane, we're not going diagonal motion, so. Anything else?
In the front.
Is your neck and shoulder associated?
Yes.
If your neck has a dysfunction, could you have shoulder pain?
Yes.
You can have shoulder pain. Can you have neck pain? Watch what he does. Every time he has to listen to what the patient has to do, he's always turning and then he's lifting. Half his range may not even show up. When you want to assess scapular, shoulder motion, sometimes in patients like this, you want to see what the patient does without the movement of the neck. You want to see, can the patient maybe go a little bit higher or not? So you can evaluate, you can move around, but you want to see how will this patient do if this patient doesn't have to move his neck every time he's listening to you and then he's trying to do that. Make sense? Okay, go ahead, guys.
Okay, so your first question was about synergy patterns. We talked about capsular patterns.
Okay.
Because it seemed like that was the thing, and it seems that his limitations do fall in the general assumed capsular pattern for the shoulder,
Okay.
which is
Hold on to that thought.
I will
Did
hold on.
anyone see any synergy happening during this thing? You don't need to have synergy. Remember, I told you synergies don't need to happen. If you have a neuromuscular deficit, if you have a neurological deficit, you can have synergies happening even if you're normal. Did anyone see any synergies happening over here?
I don't know if this counts, but he flexes his trunk.
Yes. Every time he wanted to create that motion, he had a synergistic, maybe an irradiation principle going on. He would flex his neck, flex his trunk, and lift that arm up. So even if it's not a solid synergy pattern in the arm, there were other synergies that were happening to help move that arm. So think of that as well. Capsular patterns, correct? Here you are going to look because there's a solid orthopedic dysfunction, but there's an orthopedic dysfunction. Muscles are also not working right. The rest of the body wants to assist that joint in any manner to perform it. You'll do anything to do that. Okay? So that was a somewhat of a synergy. Great job, Melanie. Go on.
So you want to go back to the capsular pattern, or you want to move on to the next thing?
I don't know. What do you want to do? You're not presenting to me. Please, class, you're not presenting to me. You are presenting to your colleagues, okay? So ask them. Emmeline, ask them what
I
they
did,
Duran answered?
Duran answered, gave me a clear idea of what I should do.
Okay.
So we're going to talk about the specific dysfunction that's causing the problem.
Uh-huh.
So we're going to talk about limits in external rotation, abduction, and internal rotation.
Okay.
So I think that's that. Now we selected task. The task we were talking about was putting a jacket on.
Uh-huh. Nice.
We can
Yep. Demo it to the class.
show you who's feeling demonstrative. Then we talked about the movement patterns that you'd need. So we would need shoulder flexion.
Mm-hmm.
Wait, so this is my non-involved solo. So this is the involved side.
Mm-hmm.
So shoulder.
Internal rotation,
Mm-hmm.
and then your.
Probably some shoulder protraction, scapular protraction that's happening, right? Maybe some trunk extension also going on if you're really trying hard, right? You can't find this jacket sleeve.
Yeah.
Yep.
Once you're in the sleeve, you start to rotate into a supination and external rotation.
Mm-hmm.
And then you're gonna get shoulder flexion and a little bit of horizontal abduction.
Uh-huh.
So, yeah, those are things that.
Very nice.
So the next thing to do is to determine at least 2 PNF techniques. And the 2 week shows were quick stretch and maintained isotonic.
Mm-hmm. And pull up contraindications for quick stretch for me. It's in
So this is quick stretch to help with the limited abduction that the patient has. So I would just have to, since he's limited like this, I would be like, okay, I'm going to apply a quick stretch into this direction, and as you feel your arm move up, I want you to work with that, okay? All right, ready? Down, and then work with it. Good. And again, down, and work with it. Good. And then we repeat that several times.
Okay, very cool. Anybody has any issues on that? Do you think they did a good task?
I don't know if that's such a good stretch shoulder. Like
Okay.
you're trying to stretch abductor.
No, I thought the quick stretch was like if you stretch, I don't know, maybe I did it in the wrong pattern, but I
No.
thought it was like,
Answer his question. What were you trying to stretch?
yeah, I was just trying to stretch the abductors. So if the abductors contract like this, then I'm stretching it by doing this. and by pressing it down, I'm lifting it
So you
up.
don't have to go all the way
Yeah.
into across your body to create that elongation. Just being in this position, your abductors are already extended. When you are here, they are contracted. So even if you perform little quick stretch as the patient moves up, little quick stretch as the patient moves up, that is a repeated quick stretch. So no, that was fine. You did the
Okay.
correct. So when you think of the pattern, you could have a pattern which could be in synergy, doing this, or it could be breaking down each movement. So that's fine. You did fine. But would we want to do quick stretch in everything? Go on, man. Go on.
You have contraindication for quick stretch, which is pain and hyperactive stress reflex not under voluntary control.
I don't think so. They can hear you. Be louder.
So for quick stretch, we have contraindication, which is pain in this case.
Now they said, How do you think? Do you think it is a contraindication in this patient?
I don't,
You don't. Why?
because I think the point is to get more mobility into that joint. 'cause
Okay,
we-
so she's a person who will be like, no pain, no gain. I'm going to crush you down. I don't give a damn. Yep, go for it. Go for it.
Crusher.
What do you think? Do we think like that? Your answer still stands correct. I can think like that, but I don't agree with your rationalization.
It's
Yes.
okay.
Well, she's doing the quick stretch in the opposite direction where the pain would be, because wouldn't the pain be into the abduction?
Yes. However, they chose the lowest range of motion. If they had decided to do a quick stretch right here, the joint was already in pain. So their first question when they choose to do quick stretch, or when you guys choose to do quick stretch, you have to ask the patient, are you in pain in this position? Then you have to plan. If patient is in pain, do we do quick stretch? If patient is having a dislocation here, flaccid joint, do we do a quick stretch? No, answer should be loud and out. No, we don't do that. Somebody is dislocating a shoulder, you want to do a quick stretch? Boy, you have a legal lawsuit against you, right? What if patient is severe stroke? You tap them and spine cramp like that. Do we do a quick stretch in that case?
No.
If you cannot control that movement, if you as a PT cannot control that movement, we do not give a quick stretch. This patient didn't have a stroke, great, had some pain, but if you kept them in a pain-free range, this is a good technique to facilitate the patient to get into an abduction position if they're not able to do that, right? But if they're already able to do that and they have strength enough, do we spend our time doing quick stretch here?
I guess.
You guessed not, you're correct. Maybe while they're doing TheraBand and they can't generate it, you can quickly give them a quick stretch. All right, try it now. Try it now. Okay, so that was great. Good technique. And what was your second technique?
Well, I don't know.
What did I just say after the first?
Well, I'm not sure that okay, now rethinking it, I'm not sure it was the best decision.
That's okay. If you are not going to error in class, where else will you error, guys? You are meant to make errors here.
Let's error.
Yes,
So
let's
my
error.
error here.
I would
was-
rather error here than with the patient, and the patient's like, I never want to see you again.
Okay. I'm happy to error, and what we decided to do was maintained isotonic.
Demo it on the patient, please.
Good luck to us.
Yeah.
That was the one I didn't quite have.
It's okay. If you're gonna make error, maybe somebody else who's seen this video is gonna correct you, and these guys have, right?
Like the one show
Good.
maintained isotonic. Jump in.
No, you do it first. You have to error first.
We'll figure it out here, we'll get feedback. So,
Take your
for
time to
this
get
one,
feedback.
you were focusing on the ER/IR part
Okay.
that they're limited in. And so what I want to do is, since this patient seems to be just comfortable right here,
Right.
to help with the IR, we would ask the patient like, okay, can you just hold it here and
Guys, watch them very carefully because I'm gonna come down to one of you guys now. Watch them very carefully what they're doing.
and then so I would ask the patient, so hold it here.
Is that maintained isotonic, guys?
Don't let me move you.
Yeah, Jasmine is right. Patient's teaching the therapist this time.
Don't let me move you.
Maintained isotonic. We are wanting to create the motion. So we were like, don't let me move you. That is the command you want to give to this patient.
Because on the slide it says something else.
Oh,
Holding, if you just hold the position.
So which one, no, I just want to say it out loud so that I
Yes,
remember it.
yes.
So maintained isotonic
Yep.
is don't let me push you.
Don't let me push you. So your force is, while you're creating that force, now what are you trying to do? Abduction? What are you trying to do?
The IR.
So if you're trying to do an IR, so you know, see what she's doing. She's going to do that, right? So do we do that in sitting position? That was my question next for you guys. If you're going to give her, don't let me move you, right? Don't let me move you, Jasmine. Don't let me move you. Yep. This portion of the trunk has to be stable, right? Now, when I'm going to give all those who can see, please come here behind me. When you're doing maintained isotonic, you have to go into the, don't let me move you, okay? When you're doing a hold position, or an isometric position, you go into, you be like, hold this position, hold it, and you're building resistance, which basically means when I first begin it, if I want her to hold this position, hold it for me, hold it for me, hold it for me, hold it, okay? Now I'm going to tell her, don't let me move you. I'm going to try to move you down. So don't let me move you. 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 That's what you're going to do between a maintained isotonic and a hold position, which basically means an isometric position. But when I'm doing that for a frozen shoulder patient, you think they can do that? Always remember your open and closed packed positions for the joints, guys. When you're going to be in open packed positions, they're very unstable positions. Having a patient sit down and do that, you have to have a healthy patient. With pain, will the muscles be inhibited to stabilize that joint? Most likely. Pain is very low, they won't be. Then they will be able to stabilize you. But if the pain is excessive, you won't be able to have them be in this, they'll be in pain. They're like, what do I do? Follow my pain or do your resistance? So make the patient comfortable. That's the reason I gave you pillows, not just to sleep, but to make the patient comfortable. They're here to seek comfort from you. Get them in the most comfortable position and then plan your technique. Techniques are not wrong. Once you practice them, like you did, now will you remember that, Magina?
I don't know.
You don't know? So then what do we do if we don't?
I'll just ask you again or Google it.
That's fine.
Yeah.
Even if we can take 5% of what we learned in this class, that's great. But you have to review it, guys. I'm here with you only once a week. You will have to go back, go through it, and practice it on each other. Let's take a break, okay? Let's just take a break. We'll come back and we'll